Thank you. Good morning, or in my case, good afternoon, because I'm from Virginia. So I'm going to be talking about education and health, and I want to begin by just sort of setting the table in terms of what I mean by that. Sometimes when I talk about education and health, people think, oh, you mean patient education, making sure our patients are well informed, and that's important, but no, that's not exactly the focus here. What do I need to do to bring up my slides? Oh, you got it. Okay, great. Then some people think, well, when you mean education and health, like with school children, you mean teaching them about healthy diets and nutrition and the fact that you shouldn't smoke. And that's important too, but that's actually also not what we're talking about. The focus here is on the relationship between educational success and health. And Josh was right, these are two silos that for many years have been working towards similar ends, but actually not communicating with each other. But increasingly, in part through the leadership of the Roundtable, there's been more attention paid to the interconnections between education and health. All right, let's see if I can get this to work. Do I point it somewhere, or? Which way? That way, okay. Okay, so let's start at the 30,000-foot view. What shapes our health? How is population health, the health of Americans, affected? So if you think of the box on the far right-hand side as health, there's 5 domains that you can think of that are important to shaping our health. One of them in the upper right-hand corner is the one Americans automatically think of, healthcare. But health is about more than health care. It only accounts for about 10 to 20% of health outcomes. We also know that individual behaviors are very important along with health care. So whether we smoke, physical activity, diet, and so forth are hugely important. There is unfortunately a tendency for people to stop there and think, well, then that's what drives health. But both our access to health care and our health behaviors are influenced by our environment. And by our socioeconomic conditions. By environment, I mean the physical environment, such as whether you have access to places to be physically active or to get healthy foods, and also the social environment. Stress, trauma, residential segregation, things of this sort also influence our health. But up in the upper left-hand corner, we know that socioeconomic factors are hugely important, and I'll be showing you data in a few minutes to back that up. And that's where education lives. Obviously, all of these boxes have bidirectional arrows connecting them in a myriad of different ways. They're all very interrelated. But the one at the bottom is pretty important, the 5th domain, public policies and spending, because the decisions that we make as a nation, at the state level, and our communities, actually drive the other 4 boxes as well. So the environment that we have, the quality of the schools that we have, health behaviors, access to health care, all of that obviously is being shaped by policymakers, elected officials, our private sector, and so on. There we go. So when we think about that schematic, and people ask me, so, you know, what accounts for differences in health outcomes? Later on, I'm going to be showing you differences in health outcomes that we see even within a city, within geographic areas. This is the laundry list of things we often talk about. And I won't take time because I want to be brief in this introductory talk to get onto the rest of our program, but you'll see that the bullet at the top, education and income, is uppermost in our minds. The evidence about the influence of those other factors is also huge. So the quality of housing, the built environment, the environmental pollutants that we're exposed to in our communities are all very important. But education and income, and I would add wealth, are probably some of the most powerful predictors of health outcomes. And so what we're going to be focusing on today occupies that space. And I want to focus a little bit on about why the data and the evidence and the research takes us to that as an important priority. So this is a graph showing you the relationship between all-cause mortality, in other words, the risk of dying from any cause in the United States, and educational attainment. So plotted on the x-axis is how many years of education the population has had, and you can see a pretty clear relationship. One curve is for men, one curve is for women, and you can see the more your education, the lower your risk of death. This concept of a gradient is something that I'm going to emphasize. You can plot any number of different health outcomes. In this particular example, it's all-cause mortality. In the next one, it's self-report of health. And you see this stepwise gradient where people who have less educational attainment have worse health outcomes, but the problem persists. So even the differences between people who have some college education and those who get a 4-year degree, there is a measurable difference in health outcomes. And even beyond that, we see differences. So that it's a general principle that the more education people have, the better their health will be. In a minute, we're going to talk about why that might be. But this gradient, you can put it up for asthma, diabetes, any number of different health outcomes, you see the same story. Because there is a tendency in America to assume that health is about health care, we actually did some analysis for one of our projects on education and health to try to show that even when people have equivalent access to health care, that gradient persists. So this is data from Kaiser Permanente here in Northern California that we collected a few years back. So here you have a population in a health system where it's not exactly identical, but most members of that population have similar access to care and similar benefits, and still you see a stepwise gradient in health outcomes, which tells you that the differences in health outcomes that you see by educational attainment have more to do with things outside the hospital and clinic than inside the hospital and clinic. The impact of this is, I think most people sort of get the general notion that education and health would be interrelated, but people probably don't appreciate how big a deal this is. So this table overwhelms you with a bunch of numbers, and it may be hard for you to see in the back of the room. But basically listed there are any number of different kinds of diseases, coronary artery disease, diabetes, kidney disease, and so forth. And the different columns represent different levels of educational attainment. And if you look at the numbers, you can see how there is a significantly higher percentage of people in the lower educated population who are faced with those diseases. So as a clinician, that means that I, in my practice or my health system, are going to be seeing a greater risk of these chronic diseases in our patients who have less educational attainment. But really, this has broader implications outside the health sector for our country and for public leaders. So say you're an employer, for example, the business community, a major corporation. What you find is that if you look in this particular table, it's showing you levels of physical function. Say you're UPS. The ability of your workers to do heavy lifting and other types of physical functions shown in this chart is much lower if they have less educational attainment. So from an employer's perspective, looking at this data, they're thinking about how education is going to not only give them workers who are more capable and physically functional in jobs, in blue-collar jobs and so forth that are more dependent on that, but increasingly in our economy, the need for a well-educated workforce that has IT skills and other technical skills that are important for the major industries that we have in this country. Healthcare costs are going to be lower for employers that have a more educated population. There's going to be less absenteeism and presenteeism and so forth. So education and health is a big deal from the corporate perspective. I could go through other perspectives, health plans and others, where there is an important connection between education and health that is getting our attention. Again, in our society, we tend to focus so much of our expectations and resources on health care. I don't know, $2.6 trillion now in the healthcare system. We pour tremendous amounts of money into that, but we don't appreciate how much more important it might be to address the social determinants of health like education. This is a study we did a few years ago where we tried, it was a thought experiment that basically tried to calculate how many lives have been saved in the United States through medical advances, so developing new drugs and new technologies and so forth. And how many lives would be saved if everybody in the country, if all adults, had the mortality rate of people with some college education. So the tall bars in the back are the number of lives that would be saved if everybody had the mortality rates of people with some college education. And the little stubby bars in the front are the lives that were saved through medical advances. So it's a ratio of about 7 to 1. For every life saved by medical advances, 7 would be saved if we were to close that gap. So it's a big deal. Now, education and income / wealth are very hard to disentangle, especially in a knowledge economy. So the people who have more education are going to be more likely to have higher incomes and greater wealth. And so we are not surprised to see a similar kind of gradient that exists between income and health. I'm not going to take time with it, but I could show you more bar charts with stepwise gradients for different health outcomes where you'd see the same thing based on income. Not surprisingly, it's not just physical health that's correlated, but in this particular example on this slide, mental health and psychological well-being. Makes sense. People who have less income are going to be under greater stress from coping with their living conditions. So you see higher rates of hopelessness, sadness, worthlessness, and so forth that exist among people who are more economically distressed. The changes that are going on in our society are impacting those with less educational attainment more dramatically. So the life expectancy of people who have not graduated from high school over time has decreased. The trend we want to see, and typically is seen in industrialized countries, is a gradual increase in life expectancy from year to year. But now we're seeing that people who have less than a high school education are seeing their life expectancy decrease. This trend was actually recognized some years ago at a time when U.S. life expectancy was still increasing. Now, U.S. life expectancy in general for the whole population is decreasing, but it's decreasing even more dramatically among those with limited education. The work of Case and Deaton and other researchers in recent years has drawn attention to this problem of deaths of despair. We're seeing dramatic increases in deaths from drug overdoses with the opioid epidemic, from alcoholism, from suicides, which has gotten a lot of attention recently. But Case and Deaton and other researchers have shown that this increase in deaths of despair tends to be concentrated among the Americans with less educational attainment. And it makes sense. The kind of economic vice that we're talking about that exists for people with limited education is potentially driving people to greater levels of frustration and hopelessness that may be leading to these acts of desperation. Okay, so why is it that education and health are related to each other? So let me walk you through this diagram for a second. One way we can think about the relationship between education and health is the one that probably comes to mind right away, and that's that big arrow that's going to the right. If you have more education, then you have the ability to access more economic resources. You can get a better job. You're going to make more money. Your job's probably going to have health insurance benefits. The resources and the income that you get from that job will allow you to live in a healthier neighborhood and avoid other kinds of hazards that affect your health. We're going to talk a lot today about the direct arrow going in the opposite direction. Reverse causality, we call it in epidemiology, but it's the notion that health results in better educational outcomes. So whether we're talking about a child with ADHD or a child with asthma, better health and better management of those conditions is going to lead to better academic success. But the one thing I want to make sure we don't forget about in this discussion is that big green box at the bottom, the contextual factors. There are conditions that our young people are exposed to early on in the first 1,000 days of life and in the run-up to their education and then during their education that affect both their health and their education. So for an example, let's talk about chronic stress and trauma. So if you're growing up in a family that's dealing with divorce, or you live in a neighborhood that's very unstable where there's a lot of violence, if you're exposed to toxic stress and so forth, it is going to affect your health. I'll talk about that in a second, about the health trajectory that stress produces, but it's also going to affect your success in school. And so you end up with this correlation between education and health, but the real root cause of that is actually those contextual factors, the stress that the child is living with. So if you live, for example, in a city that's struggling with the kinds of problems that occurred in Baltimore and other cities where we have tremendous social stresses and traumas that both young and old are dealing with in living conditions, those are going to produce toxic stress that has adverse consequences both in causing a higher risk of substance abuse, but also later on different rates of chronic disease. So you're familiar with adverse childhood experiences, or ACEs. Research has shown that children who are exposed to those kinds of toxic stresses end up having a higher rate of risks of depression, substance abuse, and these types of chronic diseases later in life. And they also don't do well in school, so you end up with that correlation. When we look at our cities and in rural areas as well, we recognize that there are big differences in health outcomes by geography. So this is an example from Chicago showing the differences in life expectancy by census tract, where you can see in areas like Southside Chicago much lower life expectancies. It shouldn't come as a surprise, based on what we've reviewed so far, that if you were to map educational attainment in the same location, you end up with a very similar kind of map in terms of the areas that tend to have the lower life expectancy are also areas where educational achievement, in this case graduation from high school, is less likely. And so this reminds us that about the importance of place, that the conditions in our communities shape both health outcomes and educational outcomes. We can obviously think about how a low-income neighborhood with lower property values and lower taxes going into the school system affects the quality of the schools, but we also have to think about the living environment, racial segregation, and other factors that affect the child's ability to succeed in school, as well as their health trajectory. A lot of efforts are underway, we'll hear more about them today, to try to draw a connection between the community conditions and the child's experience in school. This is the whole school, whole community, whole child model that the CDC has developed, and we're working actually with colleagues at Washington University on a project that is basically trying to implement this in the St. Louis City school system and Normandy school system in the St. Louis area to try to provide this holistic approach that helps improve the community resources that are available to children as well as their experience in the school. And I'm sure we're going to hear many more examples of this today. So I'll stop there in the interest of time and then take questions. If there are any.
Webcast can hear clearly. Questions? I know there will be some. I just want to thank you for providing such a great evidence base for the start to this. And I will ask the first question while people are getting going. I know this is not a shy crowd. Everybody's, I know there was just a victory celebration, like literally right outside here, so maybe everybody's still tired if they got in early and saw that. But my question is, how does the data on the importance of education for health, what is the state of appreciation of that, do you think, among healthcare leaders? And how, at this point, do they think about this connection? What's the base that we're starting with there in terms of that appreciation?
So that's a great question. I think for many years there's been a lack of awareness in the healthcare community about the importance of the social determinants of health. So that's the term that we use in the public health world for this group of conditions like education that affect our health. In recent years, though, healthcare systems have become more attentive to the issue of social determinants of health, in part because of health reform. So their responsibilities for, under the Affordable Care Act and other health reforms, of being responsible for improving population health outcomes and lowering utilization of healthcare services have drawn them to recognizing the importance of those factors. Typically, though, the focus has been on things like unstable housing, for example, which is a major driver of poor health outcomes, and food security and other kinds of factors that healthcare systems seem to have an easier time getting involved with. But I think increasingly there is a recognition that they have a role to play in trying to help young people succeed in education, and I should mention as well the need to help their parents who are in low-skilled jobs obtain education to compete for better jobs and earn higher incomes. So there are examples of healthcare systems that are trying to support those efforts. I think we'll hear about some of them today. But I would say it's been less prevalent than their investments in resources like stable housing and food security.
There's been some stuff in the news the last few days about Korea. Maybe you saw it. But one of the pieces on NPR was a contrast between North and South Korea and what's happened over the interval between the Korean conflict and now, and how life has changed. And that one of the arguments was that South Korea moved ahead in a lot of areas because they heavily invested in education, and in particular, education for girls. And that, in fact, when I've looked at that data, and that the post-secondary degree rate in South Korea increased more than any other country in the world over the last 50 years. And life expectancy for women went from like 55 years to it's getting close to 90 years. But my colleagues keep saying, well, that's a correlation, that's not causation. And in fact, I noticed in your talk, you actually used the term cause on a couple of occasions. Do we have to worry about that? And do we still have to struggle with making the argument or improving our methodologies to prove there's causation, or at least to make a better argument for causation? Or do you think we're beyond that?
That's a good question. I think probably my academic colleagues would say that we're still not where we'd like to be in terms of having prospective evidence that improvements in education will improve those outcomes. When I showed you that ratio of 7 to 1 and those big tall bars for how many lives would be saved, there are assumptions in there that may not be valid. Just giving out diplomas doesn't save lives necessarily. But there have been enough examples, like the one you mentioned and a few others that have gone on around the world, actually, that clearly show. I think we could quibble about the magnitude of impact, the effect size, but the question of whether improving education will improve health outcomes, I think, is pretty well established. On the point you're making, though, as you know, Bob, in his earlier time at HHS, helped support a panel that I had a chance to chair by the National Research Council and Institute of Medicine that looked at the health of Americans compared to people in other high-income countries. And we found that Americans' life expectancy and other health outcomes is much poorer than in those other countries on many, many different measures. And when we undertook a systematic examination to ask the question, why are Americans so sick? Why is it that we do so poorly compared to other countries? We looked very carefully at how we compare to those other countries in terms of those 5 boxes that shape health. And education was one of the ones that stood out. It used to be, post-World War II, that Americans were the most educated people in the world. And over time, our educational outcomes have not kept pace with progress in other high-income countries, but also in developing economies like South Korea and other areas that have outperformed the U.S. in terms of their ability to educate their young people and prepare them for successful careers. And one other difference that might account for that is that these other countries also invest more in social services, education, and other factors that improve health. Per capita, or as a proportion of their total spending, these countries often outperform the U.S. in making education a priority. So one implication of that from a policy standpoint is that our country needs to shift its priorities not only to improve health outcomes, but also in terms of economic competitiveness with these other countries. Our ability to produce workers who can challenge the performance that we're seeing in other countries is at risk if those kinds of investments aren't made.
Great. I have a comment and a question. The comment is, would you mind moving my name tag from right in front of you there? Just in case my mom is watching the webcast. Okay. And yeah, there we go. That's better. Excellent. It was excellent. I would love to have your talk attributed to me. The second question is, as we think about health challenges in the United States, we think about the incredible inequities that exist in health. And could you talk a little bit more about how education relates to those inequities? Is it just sort of separate from them? Is it integral to them? How do you think, and what is the evidence around the role that educational challenges play in producing the serious health inequities by race, by location, by other key factors.
It's a key point. The 5 boxes that I showed that shape health outcomes also drive health inequities. There's other special factors that influence health inequities, such as racial discrimination and racism and so forth. But if we look at differences in health that exist among people of color, for example, compared to those with in the white population, we often see that they are mirrored by very dramatic differences in educational outcomes. So African Americans are, as an average, going to have a lower rate of graduation from high school, less success in obtaining 4-year degrees for a variety of reasons, many of which are the result of racist policies in the past. But the importance of this is that this cycle of poverty that often exists in disadvantaged populations and in marginalized communities, the way out of that cycle of poverty very often, especially in a knowledge economy, depends on the ability of young people to get a good education. So it's fundamental that we recognize the importance of education in shaping not only health outcomes, but economic opportunity and social mobility, and that investments in addressing those gaps that exist very often to a greater degree in marginalized populations is probably going to do more to improve not only health outcomes, but end the kind of economic vice that many of those communities are stuck in.
Hi, Sandy Magnan, co-chair of the Roundtable. Thank you so much, Steve, for your excellent talk. Your comment about the post-World War II made me think about the messages that were sent to young people at that time. You got to go to college, and parents were so proud, and they did sacrifice. Do we still see those kind of messages kind of in this age of despair and hope? Are we still seeing those kind of messages sent to young people? And then second, you hear a lot of talk these days about, is a college education really worth all that money that you'll be paying, and should we be investing more in some of the crafts, trades, vocational, and do we know anything about that kind of education and effect on outcomes?
Well, those are both great points. I think you're right that in that post-World War II generation, there was a strong interest in education, not only for young people at the time, but the vets coming home from the war, taking advantage of the GI Bill to try to finish their own education. That was a high value. I don't think it's the case that in today's society parents aren't encouraging their young people to attend college. I think there's a fair amount of pressure on today's high school students to perform well and try to get into the best schools. The problem is barriers to accessing that college education, whether it's due to racial and ethnic disparities, for example, that feed into that, and also the cost of college and the kind of debt that young people face by pursuing that education. State economies that are hobbled by the growing costs of Medicaid have invested less in state universities and faculty salaries, and so tuitions have had to climb to compensate for that. And it's caused a pretty vicious cycle that I think has created barriers to a college education that the prior generation didn't face. I think you're right, though, to point out that it doesn't have to be a 4-year degree that can get you out of that cycle of poverty. I was just in Kansas recently where we were presenting results of a study we had done on rising mortality rates there. And they were quick to point out that in many of the rural areas of Kansas where they're having terrible public health crises with mortality rates increasing, they need solutions beyond 4-year degrees because the young people in those communities that go off to 4-year colleges don't come back. They don't want to return to those rural communities that are struggling. But there's also a great need for people in the trades, bricklayers, masons, and others. There are jobs waiting for them, but there often aren't people trained in those trades to take advantage of it. So I think you're right to recognize that.
Thank you. Great talk. Sally Kraft from Dartmouth Hitchcock. Along those lines of the debt incurred with education, has there been any research to indicate that innovative ways of delivering education at lower cost, the MOOCs and the, I don't even know all the different terms, can have the same impact on increasing education attainment and the increase in income and wealth subsequent to that?
That's a good question, but I know it's outside my expertise. There's probably other people in the room who can answer that better, because I'm not familiar with that area of research. Thank you.